mute you earlier, my mistake, so sorry. You'll be discovering a little later on in the programme that Dementia for Medics is part funding a fundraising initiative by an adventurer, a young Swedish adventurer, who's biking around the globe to raise funds for dementia research. And these gifts are a kind of memento of his efforts in lieu of our own biking efforts and more exercise for ourselves. And remember I said, ladies and gentlemen, let's try and bring positivity into this discussion. So perhaps, Deborah, wherever you are, the suggestion that came from the room to perhaps energize these guidelines would be what came from Chuck, which is perhaps to give these guidelines even more impetus. We all need, and the WHO needs, to say what the impact could be, just how powerful these guidelines and these measures could be to reduce the impact of dementia. So Chuck, I hope that's helped, yes, big thumbs up from Chuck, in how we can move these discussions forward. Okay, so now we're going to look at a much used word, a bit of a buzzword. What does it really mean in this dementia space? And that is innovation. Let's drill down into some innovations going on in the dementia space. I would like to invite up from Ireland, the Minister of State for Mental Health and Older People, Minister Jim Daly. And joining him from the OECD, thank you so much for joining us, Minister, Head of the Health Division, Ms. Francesca Colombo. Hello, Francesca. So, innovation. We hear so much about it in all sorts of fields. It's become almost like a kind of a meaningless word. Make it concrete for us, Minister. Give us some examples of what you think is innovative and innovation in this area.
Yeah, I think you started very well by saying the difficulty of words, and that's something I think that affects the entire debate we're having here. Even words like dementia and Alzheimer's and disease are also, they can be off-putting for so many people who are trying to get their head around solutions. So innovation is another one of those words. I think innovation is best captured in its most simplest form, and it's the very, very small steps. For example, I'll give you an example of innovation just on the ground, where you look at people with advanced dementia who are being cared for in a residential facility. And when you see there's a movement out there now towards the clinical staff, the nursing staff, doctors wearing ordinary clothes as opposed to wearing uniform. And this is their home, this is a nursing home, and having people wearing. So that kind of level of innovation can be very, very simple. Another level of innovation then is, obviously you can look at a higher level innovation when you look at assistive technologies, diagnostics, all of that. Something that we have rolled out in Ireland under the National Dementia Office is memory technology resource rooms, which have just been, they've been established the length and breadth of the country in different areas so that carers, family members and people with dementia can come and visit one room and get to see all the latest gadgets, for want of a better word, all the latest technologies, but also some very, very simple, practical things like a clock that has, you know, the day and date in large letters underneath it, so that people with dementia can always know what day they have and what date they have. You know, those very simple things, as well as some of the more advanced assistive technologies that will, you know, alarm to remind you to take your medicine, and alarms that will tell if you have fallen or gone outside a certain area and all of that. So, but I think innovation is to be kept at its simplest, and that is where it's most effective. If you look at the small steps that can be really, really powerful.
Francesca, what are your thoughts on innovation? Is it something that just sort of happens, small steps, as it were, as Minister Daly has been saying, or is it driven by a kind of process, almost kind of an approach from above? What are your thoughts?
I mean, there is obviously the big elephant in the room that we don't have a disease-modifying treatment or a cure. So of course, I mean, you know, we end up doing lots of very needed and much needed innovations in the process of care. It's fundamental, but we are still failing on really like making a huge difference to those who will, you know, develop dementia by really trying to find a cure or disease-modifying. And we look at that for several years, really, the OECD, and some of the data, for example, they strike me a lot. They might be out of date, so it's, we at that in the context of the then G8 ministerial, health ministerial on dementia. There is like the success rate, if we go, it's really like a funnel. So you have lots and lots of preclinical trials, initiatives. And then if you look at the success rate, you go down to 0.5%. Very, very small. And what strikes me also is that if we look at the share of public funding, R&D funding that goes on dementia, it's also 0.5%. This might be a little bit outdated now, but we really did an accounting exercise of all the R&D spending, and it's really, really, really small. So in a way, we are failing on the public side to prioritize the public spending on dementia. There have been then a number of initiatives that followed this G8 ministerial event that took place.
So what can we do about that, Francesca?
Sorry?
What can we do about that? Do
So
you see innovation?
So that's the public side. Obviously, there is the failures then on the private side, on the pharmaceutical companies, and we know Biogen, the just recent clinical trials. So, I mean, you mentioned at the very beginning collaborations, and obviously we need to have much more public-private partnership in this space, because it's not by having just the public or just the private. It's just in a way you really need to be much more together. Perhaps think even of innovative down the line ways of paying for a possible disease-modifying treatment that might arrive. The big question is how are we going to pay for that? So in a way, you need to keep the incentives up for pharma to keep on innovating while also prioritizing these on the public research and spending.
Okay, so that's one idea for the room, ladies and gentlemen, which perhaps some of you would like to chew on and add your comments or question Francesca on, which is how do you create innovations to create more innovations? How do we keep pharma in this space by changing and innovating the way in which public-private partnerships happen, bringing in a different level of funding, perhaps more venture? Let's think about that in the discussion that follows. So let's move on and talk a little bit about technology. Where do you see the role of technology in innovation? I know that you've done quite a lot in robotics in Ireland. Do you want to tell us a bit about that, Minister Daly?
Yeah, I think technology will always innovate anyway, and that it's a space that's going to be difficult to keep up with, and that can be sometimes a problem because you can invest a lot of time and energy in a new technology, and by the time you bring it to reality or whatever, it can be already out of date and newer technologies. But that's a challenge that can be embraced and can be overcome and can be dealt with. Yeah, in Ireland, in Galway, we are developing a robotic kind of, which is essentially using, I suppose, human intelligence, artificial intelligence, and some robotics. Combining that and just we have what we call ecosystems in Ireland, where we combine the digitalised experts, for want of a better word, and the clinical experts, and the people who are obviously the people best informed in this area, and that is people living with dementia, and indeed their carers, and the academics, and bring them all together and trying to revolutionise how we care for dementia.
And so where are you in this robotic revolution? Is it working, or are you very early stages?
It's very early stages. I think a lot of it is just testing and is developing and trying to work towards. It's assistive technology, essentially, where people are there, in the robotic space, they can help with somebody. I think probably the biggest potential in that is probably at the research stage, and I think there's some very interesting points being made here about the collaboration. I mean, this is innovation. What we're doing here today is innovation at Her Majesty's a request to be here, an invitation to be here. This is innovative by its very nature, and we need so much more of this, particularly in the area of research. And I think if we can pool our collective resources better, rather than we in Ireland working as an island on our own. We have a national dementia strategy. We're currently developing guidelines on prescribing psychotropic drugs. We're doing all of these things on our own, and some of the other countries are doing all of that work on their own as well. And I think if we were to begin, and if nothing else is to come out of this, but just look at research and maybe just better streamline our collaborative approaches to research and pooling our resources, then we'd be a very, very dynamic
So
space.
another innovation for all of you, ladies and gentlemen. We heard earlier from the Swedish Minister about the Swedish national strategy, and obviously Ireland has, and most countries are now either have one or are developing one. Is it enough to look at these in terms of national strategies? Or do we need to innovate around that? Thank you very much, Minister Daly. So Francesca, I know that the OECD has been doing quite a lot of work on data and how to unlock the power that are in all these different data silos. We have so much health data. How might that help dementia?
Absolutely. I mean, it's when we look at health and health data, it's really quite a gloomy picture. a huge amount of data generated on a daily basis from interactions with the health and the social care system, in the healthcare, in the long-term care, and those are like in the population-wide data, the broad data. But then there are the deep research data. So it's anything which has to do, to really looking at the science aspects, to look at the biomarkers as well as to look at the biobanks. I mean, so lots of data. Those data are not brought together at an individual level. So we don't have really a picture of the care throughout the system. So in the care side, what it means that an individual who has dementia might arrive into a hospital. Nobody knows that they have dementia because the records are not necessarily linked, and I'm talking about not necessarily most of us countries, but the majority of countries. It might be that the GPs know that this person has dementia, but the hospitals they don't know, and as a result, the care for people with dementia in hospital, for example, it's very, very poor with recovery rates which are incredibly small in terms of not having a decline in their ability to function. So it's really the care in the hospital is very, very poor. But also more broadly, for the research side, the power of really bringing all these big data together, it's something which could be really exploited much more. And there are some barriers to having those data more linked at individual levels. There are some
data privacy issues, aren't
there?
Ethical issues. That's one of those.
Absolutely, but it's in a way, I would not say it's an excuse, but there are ways to have governance of data which is both privacy respectful and allows moving forward with the research agenda. I mean, it's not something which either you do one or the other. There are ways that you can have built a governance of data that allows privacy respectful use of data. And there are some, yes. Please.
So I was just going to say to the room, do you agree with what Francesca was saying? Please ask her more questions around that. It sounds like a great dream, but how do we unlock that promise and potential? So one more idea for you there. Now, Minister Daly, I want to ask you about something I saw in an introduction of an update report that you put your name to. Now, you may have forgotten what you put in this introduction, so I'm going to remind you now. And that is the need to use resources more cleverly. Resources are going to be constrained, so resources need to be reallocated to try and release, to try and address these problems. You can't just wish upon a dream that you're going to have infinite resources. So what did you mean by that? How can you reorganize systems and structures to be cleverer and release potential? What does that mean?
I suppose I have a fundamental philosophy that I've always operated under, and that is if you always do what you always did, you'll always get what you always got. And if we're happy with what we have, fair enough. But obviously we're not happy with what we have, so we need to reimagine how we do what we do every day. And that's what I see my role as a policymaker, is to try and reimagine how we do things. I'm a huge fan of telehealth, which is just a way of, I suppose, expanding the availability of a very finite and expensive resource. So how does telehealth operate in a space like this? I mean, our GPs, our primary care practitioners, our medical specialists on the ground don't have all the answers, they don't have all the expertise, but there are people in each country that do, but they're further up the chain, they're harder to access, there's huge lines and queues waiting for them. The whole area of telehealth among professionals, where GPs can flick on the screen and there's an expert consultant in dementia available on the screen to advise the GP on how to deal with the different cases of it. And I think probably the other big area is our living standards for people with dementia. I do think that one of our greatest shames in generations to come will be when we look back and see how we treated our people with dementia. And I don't want to sound crude in this, but we are locking people with dementia up in nursing homes, and that's what we're doing. And then when you look at the new model of housing, like dementia should be clinical led, it shouldn't be the carers, it should not all be clinicians. It doesn't have to be a nurse-led service, because dementia, most of the symptoms are social. Memory loss, confusion and whatever. They don't need to be kind of just locked up and kept in a space. They actually, if any of you know dementia, and we all know dementia people, love to walk and they love freedom. So I think it's new housing options for older people with expansive spaces where they can walk, and less of the clinicalization of this disease and more of the recognition that it's a social disease and the solutions are social, and that takes real courage and bravery and of course resources, but more importantly what you're talking about, it's about reimagining how we do what we do, not always doing what we do.
Okay. And Francesca, your thoughts on innovations in social care?
I completely agree. I mean, when we look at health and social care systems, we have 19th century systems trying to address really 20th century challenges, and we are trying to do the same things that used to be done in the previous century. So we have a very acute care-based healthcare system dealing with episodic needs, whereas we know that the epidemiology of disease is much more about chronic conditions, dementias, and many others. It requires much more continuity of care, community-based services, strong primary healthcare systems, link up, and I think we need to throw it, of course, when we're talking about dementia, the issues of caring for the carers as well. Those are really the ones that have the burden of caring, and they're not supported adequately. We have seen over the years some progress. So if we look even issues related to leave for care, for taking care of an elderly person, not specifically necessarily to dementia, but over the years, when we looked the first time about 8 years ago, we see that now that many more countries have that provisions that allow to have really a good leave for caring, but they're not really dementia specifics, and to what extent then those that are remunerated, there is still a long way
do we
to
need
go.
to broaden
And
that
also like
out?
innovative way of respite care, for example, is just to avoid that we have not just to take care of the person, but in the end we also need to take care of the person who takes care of. So I mean, we really need to take a holistic approach looking at the person with dementia and the carers as well.
So Francesca and Minister Daly, shall we give the audience their shout? Okay, now there's a hand up there at that end, and before you all think that I'm biased to this end of the room, may I say that I'd like to see some signs of life in this end of the room, so I'm going to come and jump on you very soon. So get your questions ready. Meantime, thank you very much for getting us started. Please tell us who you are.
Thank you. My name is June Andrews. I'm from Scotland, and I'm particularly interested in what Minister Jim Daly is saying about innovation, because we all know that necessity is the mother of...
Sorry, Professor Andrews, could you speak up a little bit, because some people are struggling to hear.
So we all know that necessity is the mother of invention, and your great challenge, Minister Daly, is to prioritise something, and I really felt it when you said how awful it is that people are locked up. So could we help you with the necessity of doing something like this by perhaps making some challenges under human rights legislation to help your government prioritise the fact that people should not be locked up?
Thank you. Minister Daly.
Yeah, all offers of help will be greatly appreciated. But I suppose the challenge is for us to deal with what we can deal with in the here and now. And I would love to see if there was anything to come from this forum. Would be, I think, the most positive step would be research always. Because if you can eliminate the disease like we have eliminated many of the other diseases that were shown on the screen here, like polio and the different ones at the very opening of this too can be eliminated. So I think that should be our very, very first focus, is to try and work towards that collaboratively and pool our resources collectively. And secondly then, yes, I mean, moving towards away from the nurse-led model of care needs to enter into the dialogue. And we need to take away ownership of this debate from the clinical space in that particular area. That when it comes to living, and people living, they should be living in communities, or if they need to be inside, not everybody can continue to live in their own home, but at least in a supported home environment with their own front door, as opposed to a clinical-led with grey walls, grey linoleum, nurses in uniform for the rest of their lives. In Ireland, and we're a tiny country, we have 4,000 people under the age of 65 with advanced dementia, with form of dementia, and putting these people into nursing homes, and that's the only alternative we have until we get there. So now the human rights is an interesting way of looking at it as well, to get it established there, but we certainly need to challenge that existing practice.
Mr. Klaus Dinkelspiel.
It's great fun to hear you, because if you say that the cost today is the GNP of Great Britain, in 20 years it will be the GNP to Great Britain, and that we can't afford. So we have to have innovation. To keep somebody in nursery room is about 80,000 euros per year. And if you multiply the number with the people suffering from dementia to 2050, it's pretty soon. You see that we have to find a completely new model. And the model shouldn't be created by states. It should be created by the entrepreneurs by the industry. And we are working on a project here together with...
Could you hold the mic up a bit higher, class? Thank you.
A bit higher.
Yeah.
We are working together with IKEA, worldwide. We are working together with Skanska, construction company. And we believe that couples should stay the whole time together, not be institutionalized. I experienced this with my parents, and they were married for 50 years. One stayed at home, one was in nursery home, two very unhappy parents. And if you go to Silvia, you will see that we have four examples of something called Silvia. And I'm sure that if you're interested, it's a flat 55 square meters where you can live. In the daytime, the people suffering from dementia is going to see them, and the other part of the family is going out playing golf, meeting friends, living a normal life, working, and in this case, you reduce costs from 80 to 25.
It's a great example of investing up front in order to make savings later on, isn't it, and improve quality of life.
As you said, in every country, you have very good ideas. If we join forces with innovations and good ideas, I'm sure that we can transform the whole cost structure, and also satisfaction will increase. Thank you.
Thank you, Klaus Dinkelspiel. Another contribution from this end of the room? Could you hold this quite high up, Dr. Anwar?
Yeah, I'll do that. I just want to add a little here and to remind everyone, I'm the Regional Advisor for Mental Health for WHO Southeast Asia region, which represents 26% of the world's population and mostly low and middle income countries. So with innovation, we would really like to look into affordable innovation to address these people who were more than 60% of the people living with dementia in low and middle income countries. So that's what I wanted to bring to the table. Thank you.
Thank you, Dr. Anwar.
Yeah,
Francesca?
Yeah, I could not agree more. And I think they're in the space of caring, looking at some of the assistive devices and so forth, they're very, very easy and quite cheap things that can be done. So I completely agree that obviously when you're looking at resource constraints, not just in resource constraints environments, but even in high-income environments, there are a lot of opportunities to do the care and in a way which is different, which is innovate in the living environments that take advantage of assistance devices that use digital. In some of the low middle income countries, even mobile phones are much more used, and for the family carers as well, it can be a wonderful tool to facilitate better caring. So very easy thing in a way that can be done to make a difference.
And here's Professor Winblad.
Thanks, Ida. I'm a professor of geriatric medicine, and I certainly see the need of also developing new pharmaceutical drugs to treat our patients. And Francesca Colombo, you mentioned the need of basic research due to the failed trials. So my question to you is, how can we also increase the support, the funding for basic research? I certainly say it's no contradiction between basic clinical research and prevention research, but still, how can we support the development of new drugs?
Francesca.
Yeah, I think it goes back to the issues of prioritizations and also political, if you want, prioritizations, like putting this very much on the agenda. When we're talking about public R&D research, there is things that can be done in terms of prioritizing where we put the resources. And in a way, if we look at the political space, there was a lot of attention that was put onto the space of dementia when there was the G8 summit a few years ago. And now, at global political level, the attention has been moved in other needed dimensions, antimicrobial resistance, for example. It's good that under the G20 Japanese presidency, there is again the issues of healthy aging and dementia a little bit into that space. But I think, in a way, you need to keep these very much high on the political agenda so that it translates into prioritizations also on where the public research funding is going.
And one more thought before we wind this discussion up.
So my name is Gunilla Oswald, and I'm the CEO of BioArctic, a small biotech company here in Stockholm. And I just want to say that it's really, really important that we continue with innovation in this important area, both with regard to diagnostic tools to identify the patient at an early stage, and also disease-modifying treatments. And we know there has been several failures just recently as well. And I just think it's so important that we do continue in this important area, basic research as well as different kind of continued innovation on drug treatments. And you asked for some positivism, and I will bring some positivism into the discussion here today. And that is actually a Swedish invention, which is PAN 2401, which was developed by BioArctic, invented by Professor Lars Landfelt, who is here today, and Uppsala University. It's being developed by Eisai, Japanese global company, pharmaceutical company, who have shown last year positive phase 2b results with effect on clinical scales as well as biomarkers. It's now initiated phase 3. It has started, initiated in the US. It's coming to Sweden after summer, and also Biogen is part of co-funding this development. And BioArctic, we still continue, it's a small company, but we continue to invest in further treatments, disease-modifying treatments. I also want to say how important it is with collaboration with academia and hospitals. And that's really, really key, as well as big pharma. So I just wanted to say there are some positives in this area. I really believe we have something here, and I look forward to helping the patients. Thank you so much.
Thank you, Gunilla Oswald. And thank you for ending us on a positive note. Francesca Colombo and Minister Daly are with us all day, so they will be around for you to buttonhole them, have private conversations, do that essential networking. For now, though, let's say a big thank you to them.